you doctors are starting to understand my philosophy of extraction and bone grafting. I focus on a least traumatic extraction process. I decide when I reflect the flap, when I don't. For most of those blowout cases where I lose some of the buccal plate or it's lost to begin with, I expose the buccal plate, good debridement, use the compartment technique to complete the missing compartments, mostly the buccal plate and the occlusal part, the sealing of the socket, and we get pretty good tissue and bone. And the last case to summarize this topic, again, has to do with the aesthetic zone. This is a traumatic injury. And this patient had two traumatic injuries. She fell on her face one time, broke several teeth, needed some root canals, had some restorations done. Then she unfortunately fell again. And the second time she fell, she had one tooth, a central incisor, that was beyond repair. And of course, the aesthetic zone has multiple challenges. We have a tooth that has some recession to begin with, an uneven gingival margin. Traumatic injuries many times don't just injure the teeth, they injure the soft tissue and bone. And she has a relatively high smile and very thin tissue, and that's going to be challenging. So I many times like to recommend to patients, let's not just extract the tooth, but let's also use some orthodontic extrusion. Let's maximize the soft tissue. We can then even immediately place an implant or not. But to be honest, very few patients actually do that. And it doesn't matter where you practice in the country, in the world. Patients don't feel like going through a few months of orthodontic treatment for extrusion. Patients don't feel like spending a few $1,000s for additional treatment. They want the issue done, but that's going to be challenging. So what I would advise to you when it comes to the aesthetic zone, stage your treatment. Don't go for immediate placements. And I'm going to put the poll up in a few minutes, and I'm going to ask you what percentage of your practice, your implant practice, is immediate placement, and what percentage is delayed. Because I find that there's a big hype around immediate placements, and I do immediate placements as well, but it's a very small percentage of my practice. So for this patient, I'm choosing option B that involves, number one, reducing number 8 below the gingiva. What's the reason? So we can remove the coronal part of the tooth, and we can have the soft tissue cover and gain some more tissue. I'll show you how this works. And I always have a very candid conversation with my patient in the aesthetic zone. And I tell them, once the tooth is lost, there's a natural process called resorption. And the resorption is in 3 dimensions, vertically and horizontally, both. The interproximal tissue can be lost. And I sometimes take a picture and I draw some black triangles. And sometimes that will convince the patient to do orthodontic extrusion. Okay, they tell me, you convinced me to do that. Okay, so what's the reason we are grinding the tooth down at bone level? And why am I complicating my life in terms of the extraction? Because what happens when you grind the tooth down? The soft tissue is going to cover, and that's free. The human body will heal itself. You'll get some additional coverage if you grind it down all the way subosseous. You will get complete coverage. You'll gain a few more millimeters of tissue. And that's just a nice way to manipulate normal healing processes and gain more tissue for your future implant site. So I did that. And only after that, I extracted the tooth. Now, it's important for you, and that's not part of this training, it's important for you to acquire knowledge in surgery, surgical knowledge in general, and learn about crown lengthening procedures, soft tissue grafting, osseous surgery, and many other procedures, surgical procedures that have nothing to do with extraction and implant replacement, because the more knowledgeable you are in regards to implant placements, you will be able to provide better implant therapy and implant surgery. And in this case, I added a connective tissue graft and added the connective tissue under the buccal flap at the time of bone grafting because I wanted to maximize the soft tissue profile. I used the compartment technique. Okay, I had the buccal plate. I just enhanced the soft tissue with a connective tissue graft, used my bone graft, and actually used the connective tissue as part of the compartment technique for the sealing of the socket, for the roof. And by using X sutures and an X suture on the buccal, that allowed me to retain my graft and get a pretty good implant site and very good healing.